So I decided that after we made various efforts to communicate better and basically ended up putting out a lot of fires of anxieties that were kind of at a crisis stage in terms of their damage on uptake of immunization, decided that we really needed to understand this growing trend much better and particularly investigate certain situations. So we've set up the Vaccine Confidence Project. I've set it up with two of us, and we've built it out now. We have about 12 people and a network of researchers around the world, really trying to understand what are the drivers, the determinants of different types of concerns, both what helps uptake as well as what interrupts it around the world. And that's really what we do. And what we're seeing is a lot of these issues around vaccines are most of the time related to other things. And it's that other thing, the other things that make it pretty interesting.
Mm. And is there a specific parts of the world that you do focus on that?
We're very global.
Global.
And actually, right now, most of the research is very location-specific, vaccine-specific. And one of the things that I had the opportunity to see in my earlier role in UNICEF was the connectedness of some of this. And with the increasing social media and communications environment being increasingly connected, that's getting even more transnational. So we're looking at how these rumors and concerns and issues spread, and we're also trying to keep a global look at it. So that's very much our perspective, with a lot of individual feet on the ground in different countries.
So in your opinion, why are there some communities that are hesitant towards vaccine hesitancy?
Well, there are some communities that are hesitant and others that are much more positive. And sometimes you have a positive community with just a couple individuals.
Yeah.
But when it's a whole community or a larger community, sometimes it's a religious reason. Sometimes that community had a bad experience with a particular vaccine, or actually sometimes with another health intervention that broke the trust with the health system or with the immunization program. Sometimes it's political issues, local politics that weigh into it, because these are government regulated, provided, distributed health interventions. So if you've got a problem with the government or the local politics, it can sometimes get played out around vaccines. So that's some of the ways that it varies by community. And then you have individuals that have either their own ideologies or alternative notions of health, or had their own personal experiences.
How would you define engagement in the context of the work that you do?
Well, in the context of our work on engagement, which we do at multiple levels, it's about dialogue. It's about moving the communication from a one-way information sharing or information promotion to making it a dialogue, to having a conversation at a patient provider level or group to group. I mean, in this environment, we want to have conversations across groups and make it a dialogue. Engagement means ownership. Engagement means involvement in a very genuine sense of the word, and not in a token way.
I was fortunate enough to attend the Call to Action conference hosted in Berlin earlier this year, which addressed how antimicrobial resistance poses a threat to us all in today's interconnected world. One of the solutions that were proposed for low to middle income countries was to provide better education on vaccines. In your view, how could this be delivered? Is it really about education, or is it more in-depth engagement needed?
I think you need both, particularly in the case of antimicrobial resistance. I think there needs to be some explanation in how it's related to vaccines, because it's not obvious that people think of AMR and they think of antibiotics. And when you throw vaccines into the conversation, I think it's important that it's clear why and how vaccines can help mitigate AMR. But I think engagement's also needed. You need local champions, you need local peers to be kind of explaining it and having some support for it.
Okay. Just leading on to that question, what other solutions could we provide from an engagement perspective in regards to epidemic preparedness and response?
Well, let's see. That's a big one. I mean, I think if you're talking about preparedness and not engagement at the time of an outbreak, which is important because you don't build trust in times of crisis. So I think really if you think of engagement as trust building, I think mapping, who are the people and the institutions, the stakeholders in a community that would be the people you'd want to call on or that would play a role in an epidemic or pandemic response. They should know, communities should know or think that through before they're actually struck by some kind of epidemic. Ways to engage is like thinking that through in advance. I know there was a lot of talk about that after a few, SARS, avian flu, Ebola. A lot of communities have faced threats, and I think in retrospect and in future, looking forward prospectively, trying to think through, well, what would we do? What would be our instinctive things we do? Who in the community should we call on? What roles should we play? I think to involve in the planning if it's a preparedness thing.
Yeah. So I guess leading on from this question is, do you feel that those involved in immunisation delivery and research are by and large trusted by the communities that they work in?
Depends on the community. But I would say that in general, or by and large, as you say, the health workers and health professionals still manage to stay at the top of the who do you trust list. While government, media, certainly industry have dropped down the list in terms of trust with the public, the health profession still has stayed ahead above the others. Now, it's a fragile lead, so I think it's really important that keeps being renewed, and we can't take that for granted. But yes, by and large, they're trusted, but again, it depends on the community, it depends on the local experiences.
Mm-hmm. So just say, for example, if you had a community that did have trust within, they had trust about the institution itself, how can practitioners or researchers better how do they improve that trustworthiness? How do they make themselves trustworthy? That makes sense.
You raise a really important point by talking about trustworthiness, because we often talk about building the trust of the public without really being self-reflective and saying, well, are we being trustworthy as institutions? And I think there are two key elements that are consistently characterized as defining trust between a person or a community and the institution. And that is, one is trust in the competence, the ability of the institution or health professionals to deliver what they say they can. And the second is motive. Individuals and communities don't always trust the motive of institutions, and sometimes individuals. If they feel like, giving them a vaccine is making somebody money, it doesn't feel so good. It makes somebody an income somewhere, but I think that's a really difficult question. If they feel like, if a person feels like we're just another check on the list, and if they get 10 checks and 10 jabs, they're going to get a promotion. They don't really care about me. That motive question is a very important one.
It's also, I guess, if I can add, reevaluating sort of the power dynamics between,
Absolutely.
the, I guess, scientists and communities, particularly in low to middle income countries as well. And I guess it's how do we do that?
Well, I think we need to recognize the power, respect. I think two big things that I've seen, heard, that in broken trust relationships that were lost, is where people felt that they were not respected. They lost their dignity. They were humiliated. And I think that to be trustworthy, there needs to be a respect of the other person's opinion. People need to be treated with dignity. And I think that that's really important. We've assumed that the good things we as the public health community have to offer are, quote, obvious. We've assumed a lot. They are good on paper, but we have to appreciate the context that these things are delivered in.
So just talking about, I guess, what community engagement can offer, I'd like to ask a question around that. As when we was at this when we were at these conferences, these international conferences, they I guess can almost see sort of an emergence of a multilateral agreement within governmental bodies about the importance of epidemic preparedness and responses, and the increasing number of participations and collaborations was seen as the focal point for that. But where do international vaccine programs sit in those discussions? Can they relate to local governments and organizations?
Well, international vaccine programs are only as good as the countries accept them. They're not useful otherwise, because at the end of the day, it's local governments, national governments that regulate, approve, put it into their system. You can have a global program, but if it doesn't have the feet on the ground, it's not going to move forward. What the international vaccine programs can do is give a motivation, an incentive, a kind of, if a national program thinks it's a good idea, but internally they're having some problems getting people on board, sometimes having a global program helps pull it along, helps give them extra external support. Sometimes the global programs can be perceived in a negative way, that people feel like it's for the World Health Summit, the World Health Organization, not for us. When in fact the World Health Assembly is made up of all these countries, it's kind of an ironic perception. But anyway,
I'd like to get a better understanding of how vaccine hesitancy is viewed amongst those who are governing international and national programs. So, in your opinion, are those governing these programs sympathetic towards vaccine hesitancy in any way? And do you think they understand the complexity?
I think there's been a dramatic change among governing international organizations and national programs about the issue of vaccine hesitancy. 10 years ago, when I was in my previous role, I was trying to bring a bit of attention to this emerging issue, and it was really tough. It was a sense that I was focusing on the negative, that I should just be positive. We've got 80+% average around the world. The others will come along, or we can manage, we shouldn't get distracted by them. Well, that scenario has changed dramatically, and I have to say in the last particularly 5 years, there's been a lot more acknowledgement of the issues, a lot more attention to them. In 2013, the World Health Organization, in response to a number of countries asking for help around this issue, said, we need to do something about this. And as part of SAGE, the Strategic Advisory Group of Experts, they convened a working group. It was myself and about 9-10 others internationally who basically got some marching orders from SAGE to do an assessment of what the state of things were, help characterize it, and give some suggestions on what to do. Because our group here had already been working on this issue, we kind of provided everything we had, which helped give us a bit of a baseline, and then some others around the table worked with that and brought their strengths. And I think we came out with some good guidance, and there is, I think, a different level of recognition. We did a special issue of the journal Vaccine with the cumulative work. In the meanwhile, there are more and more countries who are themselves looking at this issue, and many of them contact us for help with trying to assess the scope and nature of their issues and think through what they can do about it. So I think it was Freud who said, you can't deal with a problem until you acknowledge it. And I think we're at the stage of a good part of the world, both at an international and local level, has acknowledged that there's an issue here, and the next thing is figuring out how we're going to best address it.
So I guess more steering groups that bring in expertise, I guess, different voices within engagement, I guess, is seen as important.
Well, there's not a lot of appetite for experts at the local level. I think that I respect experts, and I think that it was really, particularly this global working group at WHO, it was a really fantastic, diverse international group, and I think there was a reasonable amount of respect for that. We should obviously continue to engage experts, but we need to diversify who's involved. I think what we need now is to start to be trying new ways of doing things. We've acknowledged the issue as a global community. I think we still haven't taken the leap to try to recognize that we need a quantum change. This is not just making the old ways a little bit different. This is a new problem. It has new issues, and we really need to clean the blackboard, as it were, clean the slate, and start over with thinking, what are we going to do differently?
I wanted to ask a question which I think you touched upon at the beginning, and it was about the role of social media. And as we both know, vaccine hesitancy isn't a new phenomenon, particularly in low to middle income countries, but the role of social media in exacerbating fears and propagating views is. So how much of a role do you think social media plays in vaccine hesitancy?
I think it plays a huge role. I mean, vaccine hesitancy is not new to vaccines. It's existed from the very first vaccines. The scope and scale of it has evolved. One, we have a lot more vaccines than we ever did, so there's a lot more vaccines that have issues. And I think that what social media has done, though, has amplified. There's one of my Bibles here is a book called The Social Amplification of Risk. There's a lot of risk scientists who basically started to characterize a lot of these things, actually not around vaccines. It was around environment and nuclear issues, and in an earlier era related to energy and building the confidence of communities. But the principles are very relevant, and the importance of mitigating rather than amplifying perceptions of risk. Social media makes this very challenging. It makes it challenging just in terms of how quickly things spread. The World Economic Forum does an annual risk report, and a few years ago they listed as one of the top 3 risks facing the world was what they called digital wildfires. And we've absolutely seen that with vaccine concerns. And what's happening is a mix of that with things like Google Translate or other translation tools means that these issues don't stay local anymore. They jump from country to country, they spread group to group, and it's a much more challenging environment for the public health community to catch up with.
And so what can practitioners and researchers do to tackle issues of unverified material?
Well, I think unverified material is a bit more straightforward than broken trust.
Yes.
I think that one thing is trying to get ahead of the unverified material. Well, unverified is one thing. There's a lot of unverified material, and part of the challenge is that science never likes to say anything is 100% right. So it's always has an element of unverification. If you read most reports, like the major IOM report, Institute of Medicine report in the US on delinking autism and the MMR vaccine,
yes,
that, and there's been other reports, give a confident but to the best of our opinion type of thing, which is classic in science. You never say never that it could be something different, which makes something like unverified material gives the public an advantage because there's always a loophole. But in terms of tackling issues of misinformation, of which there's an abundance of, I think we have to get quicker on our feet about it, make more, and I think where our challenge is particularly with social media, is what they call these echo chambers. The positive people talk to the positive people, the negative to the negative. And if we keep putting out correct information among those people who already know that, and maybe they'll learn a bit, but we need to figure out ways to get over that boundary between it. The trust issue is going to take different kinds of relationship building.
Agreed. I just wanted to ask, I guess this is a bit of a separate question, but in your experience, how do approaches to engagement change based on stakeholder? So, i.e., approaches to engaging policymakers versus approaches to engaging the community?
Well, I think when it comes to engagement, one of the things we always think about here is put yourself in the seat of the policymaker or in the role of the community member. What is the language they use? What are the contexts that they get their information? What are the levers that make their decisions, either as a community leader or as a policymaker or as a parent? And the language has to change. The format of how you communicate needs to change. You need to look at peer-to-peer communication. Who in that kind of policy chamber or in that local community are the ones that are probably going to be the best local advocates. So it's really getting a lay of the land and the dynamics.
Agreed. Just lastly, my last question. How important is the influence of social memory on vaccine hesitancy? And what needs to be done to address this in terms of how research is conducted?
It's a huge issue. And part of the challenge with social memory, societal memories and experience is that some of it is very deep. Like, for instance, we have led a lot of the community engagement and trust building around one of the big Ebola vaccine trials in Sierra Leone and in Ghana and a few other places. But in Sierra Leone, I mean, the countries that were affected by Ebola, their historical and social memories of just the how they were treated, this relationship with government, the distrust, those underlying relationships don't get better in times of crisis. They get exacerbated. And when you have kind of broken historic trust, that plays out in vaccines. And we've seen that in a number of settings. We've seen it, and it doesn't even have to be a previous vaccine issue. It's about a breakdown in the social memory. I wrote a paper on this actually with a colleague around at the time of the H1N1, saying that this is an opportunity to build trust rather than have it be a memory of broken trust. But for instance, in the UK, the MMR issue was on the heels of the public's a bit of distrust around how the information sharing around BSE and the mad cow issues were. In France, some of the hepatitis B vaccine anxieties were on the heels of a tainted HIV blood scandal, that there was information known and not shared. In another case, in Nigeria, the polio vaccine boycott. In the background, there was a court case about a child who had died during a meningitis drug trial, and that, you know, they felt like the information was not shared. The death was not deemed related to the trial, but they actually won the case because of not due diligence with the ethics. So you can have social memories of experiences that were not vaccine specific, but broke trust with the institutions. So to the extent that you can kind of get a read on some of the weak spots that need some TLC and a bit of relationship building, that's really important. You can't go in with your usual campaign to roll something out thinking that, you know, everybody's going to get hands on deck. Start gently in the places that there are vulnerabilities.
Yeah.
And most of the time you can find that out.
So would you say it's the case is slightly different for maybe, I guess, certain countries that may have had a particular experience with, for example, the West?
Yeah,
so
absolutely.
Countries like Nigeria, countries like Ghana that may have had, I guess, they've had an experience with, colonialism, and so on top of that, that's an even stronger, hesitance and resistance towards vaccines, or Western international organisations that want to do vaccines. Would you say it's slightly different from other parts of?
Oh, absolutely. I mean, polio, I think we wouldn't be where we are. We would probably have eradicated polio if there weren't some of these historic social memories as also current geopolitical issues. I mean, the boycott in northern Nigeria, particularly in Kano State, I had talked to some of the local leaders, and one of them said, are you joking? The U.S. has just gone into Iraq. They want to kill all the Muslims. Why should we trust the polio vaccines? It's just, it's obvious. We don't have any trust. And then, you had the issue in Pakistan where there was a CIA effort to find bin Laden, and they did a fake vaccination campaign. Well, that's not helpful either. And that has stuck in the memory. There may not have been a direct influence on people's vaccine acceptance the next month, but it sits there now as a social memory that they do things like that. They do things we shouldn't trust. And there's issues, and I picked the U.S. because of those examples, but it could be with any
Yes,
country,
of course.
any colonial regime, or any other civil war, even internal conflicts where you don't trust certain local leaders. Those things play out in health campaigns, particularly vaccination, which is so strongly tied to government and is everybody, affects everybody. I don't know, I really cannot think of any other single health intervention that touches every single person's life in the world. And in some cases, you can't go to school unless you get it. You can't, and the public is directed as to what to take and when to take it. And it's a challenge when that relationship is not solid.
On that final point, I'd like to honestly thank you, Dr. Larson, in I guess taking the time out to to conduct this podcast, in sharing your insights. So again, thank you.